This is week 5, and our lecture is on prophylactic antibiotics and substance abuse. For this lecture, we're going a little bit out of order with the book, so if you'll notice that there is information on prophylactic antibiotics in both chapters 5 and chapter 8, and substance abuse is located in chapter 7. Prophylactic antibiotics are antibiotics that are taken to prevent an infection or to prevent a disease. So prophylactic antibiotics, as far as we're concerned in dentistry, are taken by patients prior to their dental appointments, and it's to prevent an infection that's induced by bacteremia. Bacteremia is when there's a excessive amount of bacteria or bad bacteria in the blood and in the bloodstream. So on the medical history form, this is the back page that we're viewing right now. There are 2 areas on the form that could indicate the possibility of a patient needing to take a prophylactic antibiotic before their dental appointment. And a lot of times we'll refer to prophylactic antibiotics as pre-meds or pre-medications because it's a medication that they're taking prior to an appointment or dental procedure. So there are 2 main groups of people that may need to take prophylactic antibiotics. The first are people that have certain heart conditions that may predispose them to infective endocarditis. So they're patients that are more at risk for developing infective endocarditis. And also a group of patients that have had a total joint replacement. Patients that have had joint replacements may or may not need a prophylactic antibiotic. And finally, at the bottom of the health history form, outlined in red, there is also another portion that asks if a physician or dentist recommended they take antibiotics prior to their dental treatment. And this can be for other reasons that are outside of the heart conditions that we're going to talk about today, or outside of the joint replacement issues. There may be other patients that need to take antibiotics as well, and they've been recommended by their physician to do so. So that question's there to find those patients and make sure that we are noticing that and making sure we do the recommended precautions. The first group of patients that we'll talk about are the patients with the heart conditions that have a higher risk for infective endocarditis. These are patients that usually have some valvular issues with their heart. The first patient is someone who has an artificial heart valve. It can be any heart valve. It can be the aortic heart valve. It can be a mitral valve, bicuspid valve. It doesn't matter which valve it is. If a patient has an artificial heart valve, they are at a high risk for infective endocarditis infection and will need to take a pre-medication prior to their dental appointment. Next is any patient that has a previous history of getting infective endocarditis. So these are patients who may be more prone to getting the infective endocarditis and need to pre-medicate for various reasons. So they could have heart issues, they might not have heart issues, but the fact that they've had that in the past will automatically require them to pre-medicate. A patient that is a cardiac transplant and has valve problems. So you need to question your patient if they've marked that they've had a transplant, are they having valve problems, and that will indicate that they need to pre-medicate. Finally, we have congenital heart defects. These are heart defects that have occurred since birth. That's what congenital means. So a patient has always been born with this heart defect, and there's certain defects that we branch out into. Not all congenital heart defects will require prophylactic antibiotics. It's only the most high risk. So the first being an unrepaired or incompletely repaired cyanotic congenital heart disease. So this is someone who's not completely repaired, unrepaired or incompletely. Next is someone who's had completely repaired congenital heart defect, but it's been less than 3 months after the procedure. So for during that first 6 months while they're healing from the repair, they will need to pre-medicate for a dental appointment. And finally, any repaired congenital heart defect with residual defects. So if they've repaired it, but then there's also been issues, they might have some valvular dysfunction still, that would still require an antibiotic prior to their dental appointment. And these are what the American Heart Association recognizes as the most high-risk patients for developing infective endocarditis. What is infective endocarditis? It's an infection of the lining of the heart chambers and the heart valves, and it's caused by bacteria circulating in the bloodstream. The infection is usually caused by 3 more common bacteria: Staphylococcus enterococcus, Staphylococcus aureus, and Streptococcus viridin. These bacteria are important to know because they are present in our bodies normally, in our mouth and on our skin. So they are bacteria that we're commonly encountering, but in a higher dose into the bloodstream can be detrimental to these patients that have those heart conditions. Infective endocarditis is fairly uncommon. It's rare that we see patients that have had an infective endocarditis in the past. In my experience as a dental hygienist, I've only seen one patient that has had previous history of infective endocarditis, and he was pre-medicating because of this. So it's actually not a question on our questionnaire at my office, but because the patient told me he was pre-medicating, I was able to ask him why, and that's how we discovered that it was why he was pre-medding. So that's my only experience with it. It's rare, but when people get it, it's pretty severe and it's considered life-threatening. So that's why we want to do anything we can to help protect these patients and prevent them from getting any infection during a dental appointment. The way a patient usually gets infective endocarditis is the result of bacteremia, which is bacteria in the bloodstream. So how a patient in our chair can get infective endocarditis is that bacteria, specifically the oral bacteria, potentially the bacteria that's on the skin, can enter the bloodstream during any kind of medical procedure, also dental procedures. That bacteria is in the bloodstream and travels to the heart, and the bacteria settles around those damaged heart valves. And that's what I was saying, these patients usually have valvular issues. When they have valvular issues, the blood's sometimes not only going in one direction, the valve doesn't close completely, and it can cause some backflow. So when patients have valvular issues, they can get infections, and that can lead to infective endocarditis, the infection in the lining of the heart. Bacteremia is serious to us as dental professionals, especially in prevention of infective endocarditis, because Streptococcus viridins is very common in the mouth and is responsible for 50% of all bacterial endocarditis cases. So a dental procedure can really increase your risk of developing the condition. You're increasing your risk of getting that bacteria into the bloodstream that can cause the bacterial or infective endocarditis. It's also important to note that Staphylococcus aureus can infect normal heart valves. So in this case, it's not damaged heart valves. This is a normal heart valve, and it's the most common cause of infective endocarditis in IV drug users. You can think about a person who is using IV drugs. They may not be clean needles. They may have bacteria from the skin on them due to multiple uses in the arms if they're not disposing each time. So it's important to note that that bacteria can infect normal heart valves, not even just damaged ones. Some interesting information was discovered in 2012, after a growing body of literature on prevention of infective endocarditis, and this was conducted and reported by the American Heart Association, that's the AHA guidelines. And basically what they concluded that only a small, extremely small number of cases of infective endocarditis may have been prevented by pre-medicating with antibiotics. They also stated that the risks of taking antibiotics outweigh the benefits for most patients. So we're concerned about over-medicating patients. We're concerned about antibiotic resistance and creating bacteria that are resistant to antibiotics. So if we're continuously prescribing medications to patients that don't need it, then they can become resistant to that. So that's something that globally we're trying to diminish physicians and dentists from doing that. And also patients can have adverse reactions to antibiotics, nausea, vomiting, and rashes, any kind of allergic reaction. They also found no compelling evidence that taking antibiotics prior to dental appointments will prevent infective endocarditis, and that also patients, when they brush and floss normally at home, create bacteremia. If they have gingivitis at home and they're brushing their teeth, they're bleeding and they're getting that bacteria into their bloodstream, even when they are doing a daily activity at home. So they found that doing that at home is much more likely to cause infective endocarditis than bacteremia at a dental appointment. So because of this research, and this was done and this was stated in 2012, we now are only pre-medicating for the patients that are at the highest risk. So there was a lot of heart conditions in the past that we were pre-medicating for that we took off the list of requiring pre-medications. So the 4 that we talked about today are the only heart conditions that will absolutely require, you don't need to consult with a physician, they absolutely require an antibiotic prior to their dental appointments. These are the heart conditions that have been removed from the list of requiring pre-medication or prophylactic antibiotics. Mitral valve prolapse, heart murmur, rheumatic heart disease, bicuspid valve disease, calcified aortic stenosis. So these are patients that are at a lower risk of developing infective endocarditis, so that's why the American Heart Association took them off from requiring a prophylactic antibiotic. So I don't need you to memorize the conditions that no longer require pre-medication, but I do want you to be familiar with them, because what you're going to find is that this change only happened in 2012. So there's plenty of patients that previously took antibiotics before their dental appointments that are going to continue to do so. So we'll talk a little bit more in the next slide about how we deal with those patients. When patients come into the RCBC clinic, we have a specific set of rules that we follow as clinicians. So as far as how we deal with antibiotic prophylaxis for prevention of infective endocarditis, like I said in the last slide, the patients that have the AHA conditions that require a pre-med, no questions asked, those 4 conditions that are on slide 3 will always require a prophylactic antibiotic unless the recommendations change in the future prior to dental appointments. We don't need to call the patient's physician. We know that that's something that requires an antibiotic. Patients that have pre-medicated in the past for a condition that's not on that list, and they're pre-medicating due to the risk of infective endocarditis, we are going to follow the physician's decision whether or not they need to pre-med. So let's say a patient comes in and tells you that they are taking an antibiotic prior to their dental appointments due to a heart murmur. Now, we know as dental professionals that that is no longer recommended by the American Heart Association, but their physician may still require that for them. And at RCBC, we follow what the physician says. So if the physician, the cardiologist, wants the patient to pre-medicate, the patient pre-medicates, and we won't see them unless they will. So in this case, we're not necessarily following the standard guidelines. We're following what the physician or the cardiologist says. So in these cases, we will send out a pre-med verification form if we don't already have one in the patient's chart. We'll need to send this to the physician. We'll probably fax it. And we'll get a signature. They'll usually give us what antibiotic they would prefer their patient to take and what dosing, and they'll sign it, and we'll have a copy of that in the chart for the future. So again, even if a patient has a condition that's not one of those 4 conditions that is required, some physicians will require them to take an antibiotic, and we follow the physician's orders. And anyone who is taking pre-medication prior to their dental appointments will need a medical alert sticker. This will be placed in the outside of the chart in the upper right corner, and it will be blank. It will also be placed in the upper right corner of the medical history form with the reason for the alert written on that sticker. So now we're going to talk about the second group of patients that may require a prophylactic antibiotic. These are patients that have had a total joint replacement. This could be at the shoulder joint, like the first picture on the right is. It could be a hip joint, like the upper right-hand side picture is, or a knee that's on the bottom right-hand side. There are other joints that could potentially be replaced, but these are the most common. You'll most commonly see them in a more elderly patient because they've been walking on their joints more often. So it's very common that you'll see patients that have had a total joint replacement. And these patients are at a risk for getting infection around their prosthetic joint. So again, we're taking a prophylactic antibiotic to prevent an infection. In this case, it's around the prosthetic joint. So joint infections are really serious. If you've ever had a patient or talked to someone you know that's had an infection around a joint, it's very uncomfortable, it's painful, and it usually requires a surgical entry to alleviate the infection, and it potentially could result in removal of the prosthetic joint. And getting a prosthetic joint is not a small undertaking in itself to begin with, and then thinking about having an infection around it at a later time is an even bigger ordeal to handle. So we want to make sure that we follow our orthopedic surgeon, that's who would be doing the joint replacement. We want to follow those orthopedic surgeons' recommendations. And some patients are particularly at an even higher risk for a joint infection. And those are patients within the first 2 years after their joint replacement. So the body's still recognizing that joint as a foreign body. And in those first 2 years, it's at a higher risk of getting an infection. Someone who's immunocompromised or immunosuppressed, these people don't have the immune support to fight off an infection or fight off bacteria. So they have a higher risk of getting a joint infection. Same thing with type 1 diabetes. They have lesser wound healing. They have poor healing in general. Someone who's had a previous prosthetic joint infection is at a greater concern, and then other concerns like malnourishment, hemophilia, HIV, and malignancies. And also those are things that can make the body more immunocompromised. So we're even a more watchful eye over these certain patients with the joint infection. If you noticed, when I talk about total joint replacement, I've never said they will require a pre-medication. I've said they may require a pre-medication. So the guidelines are always changing, and they've been changing for the past 10 or so years. It's the American Academy of Orthopedic Surgeons that creates these guidelines. So when I graduated from hygiene school, it was recommended that a patient with a prosthetic joint pre-medicate for their entirety of their life before dental appointments. Prior to that, it was recommended that they pre-medicate for 2 years after a total joint replacement. And then in 2012, the Academy of Orthopedic Surgeons stated they created new guidelines and stated that they do not recommend pre-medicating prior to dental appointments for any patient, no matter when they got the joint replacement. And this is very similar to infective endocarditis in that it's very uncommon that patients get joint infections from dental appointments. They have not been able to pinpoint a joint infection to a dental appointment. I think that the statistics, don't quote me on this, but I'm pretty sure the statistic is 1 in 100,000 is likely to have a infection after a dental appointment in their joint. It actually might even be a greater ratio than that. So even though that there's very little evidence to support patients pre-medicating before dental appointments in this case, there are many orthopedic surgeons that want to cover their behinds, and they still are requiring their patients to pre-medicate. No one wants to be held liable in the event that someone gets a prosthetic joint infection. So there are some orthopedic surgeons that want patients to pre-medicate for the first 2 years, the first 5 years, and some say for life. So it's up to us to get in contact with the orthopedic surgeon to see what they recommend. Because at RCBC, we're always going to follow the orthopedic surgeon's recommendations. So if a patient comes in with an artificial joint, if that's something that's marked on their health history form, and we've not previously discussed it with the patient, we've not sent that pre-med verification form, we will need to send one to their orthopedic surgeon to get their recommendation in writing and in the chart with their signature so that we know what the physician is recommending for that patient. And we will always do that. And if they do require an antibiotic before appointments, that medical alert sticker will need to be on their chart. There may be other conditions that you would run into that a patient may be taking an antibiotic prior to their dental appointment. A patient that is undergoing chemotherapy may have a depressed immune system, and their doctor might suggest that they take antibiotics prior to dental treatment. Going right into those with suppressed immunity, patients may have a disease that is causing them to be immunocompromised. Patients could be taking immunosuppressant drugs because of potentially an autoimmune condition or other reasons. And also patients that had taken the diet pills. If anyone remembers back into the later 90s when they were removed from the market because of their cardiac side effects. So these drugs caused issues with the valves of the heart, and they noticed that after patients had been taking them for a while, and now they're banned. But the most common one that I've heard of is fen-phen. Redux was also pretty common. As you can see, it was on the cover of the Time magazine at some point. We touched on earlier why pre-medicating before dental appointments is important, and we talked about how Streptococcus viridans is a common oral bacteria, and it's also a common bacteria that is responsible for a lot of infective endocarditis cases. So basically, during a dental appointment, there's a lot of procedures that we do that are going to require tissue manipulation and bleeding and have the potential for bleeding. And when we have bacteria in the mouth and we have bleeding, that means that there is an entryway for the bacteria in our mouth to get into the bloodstream. So that's why they have recommended prophylactic antibiotics for certain dental procedures. And the guidelines for that is any and all dental procedures that involve tissue manipulation, so manipulation of the gingival tissues, the periapical region of the teeth, so around the apex of the teeth, or any perforation of the oral mucosa. So we'll go into detail about which dental procedures will do that. And I also wanted to take note of two different types of patients. So on the top there, we have a relatively healthy patient. We can see that she has very pink gingiva. I'm saying it's a she, I'm assuming it's a female. Sorry, guys in this class. But the tissue is very pink, it's very firm. You can see that there's little plaque, little calculus on her teeth. So she's a relatively healthy patient. And in those kind of patients, they have a relatively low level of microorganisms, and their risk of bacteremia is going to be low. Even if we clean this patient's teeth, there may be very little bleeding with this patient. So there's little bleeding, and there's a lower level of microorganisms because she's cleaning her teeth properly at home, and there's not a lot of plaque buildup. And then we looked at the bottom picture where we see a more diseased person has periodontal pocketing. There's a lot of bleeding evident. There's calculus. You can see that the tissue is really red. It's bulbous. It's edematous. So in this patient, the risk of bacteremia is going to be much higher because there's going to be a lot of bleeding and there's a lot of bacteria in this person's mouth that can enter the bloodstream. So not only do we have to think about the risk of getting infection based on their condition or their prosthetic heart or prosthetic joint, you also need to think about it patient to patient. Which patient is more likely to get an infection, a healthier patient or a not healthy patient? So we take that into account as well. Here is a list of dental procedures that would not require antibiotic prophylaxis to treat them. So even if these patients have a heart condition that requires an antibiotic prophylaxis prior to their appointment, they would not need to take it due to the procedure that we're doing. So if we're only doing a head and neck exam and we're only using a mirror, we're not manipulating the gingival tissue, we're not likely to cause bleeding. So all of these are going to be treatments or procedures that are very low likely to cause bleeding. Suture removal. It seems like it would cause bleeding. It really has a very low incidence of bleeding. Placing a rubber dam for endodontic reasons or potentially for doing a filling restoration. Taking impressions. For us, it's important to know that exposing radiographs do not need to pre-medicate for. So if a patient came in and didn't pre-medicate, there's the potential, and needed to, there's the potential that we could take radiographs on them to get those out of the way and have them come in for their next appointment and they'd taken that antibiotic prior to their appointment. Orthodontic adjustments don't need it, restorations of crowns, and it's not required the administration of local anesthesia. So even though we're piercing the tissue, it is a low-risk procedure, so it does not require antibiotics. However, if we're administering local anesthesia, we're probably going to be doing something that's going to affect the gingival tissue. So the administration itself doesn't need it, but any procedure following potentially would. An intracanal endodontic treatment. So inside the root canal, not beyond the apex, and a fluoride treatment would not manipulate the gingival tissues, so would not require antibiotic prophylaxis. So on the other hand, these are a list of dental procedures that are considered more high risk and more likely to cause bacteremia due to the tissue manipulation and bleeding that's expected. So as you can imagine, a tooth extraction, placement of a dental implant, any kind of periodontal surgery, and in red here is our dental hygiene procedures. So scaling and root planing, which some people refer to as a deep cleaning, probing using the periodontal probe would require antibiotic prophylaxis because bleeding is definitely likely. any kind of recall, maintenance appointment, and instrumentation that we would be doing on the teeth, and a prophylactic cleaning. So just a regular dental cleaning, a preventative dental cleaning of teeth or implants, and bleeding is expected. So very, very few patients are not going to have bleeding during a dental cleaning, at least at some point. So in general, a prophylaxis, a cleaning, is going to require a antibiotic if the patient's risks require it. Here is a review slide of the high risk and low risk dental procedures. It's a nice review to look at it in chart form as far as comparatively what can be done. So the high risk procedures are going to require antibiotics if their condition requires it or a physician requires it. Any of these high risk procedures are going to absolutely require them to take it before their appointment. If they are having a low risk procedure done, or they haven't taken their antibiotic and we want to do some things that we can do, you can do a low risk procedure without the antibiotics unless significant bleeding is expected from that procedure. So most of these procedures are very routine and not invasive. So that's why we consider them low risk, and that's why antibiotics would not be needed if that's all we were doing. There is a regimen that physicians and orthopedic surgeons usually follow when they're prescribing antibiotics to their patients. So I do want you to know the regimen, the suggested regimens for antibiotic prophylaxis and for the different patient types. If you've noticed this whole lecture, I've been talking about taking antibiotics prior to their dental appointment, but the recommended time before a dental appointment is 1 hour prior. And this allows the patient to take the drug, digest the drug, get it working in their system before we start working on them. For most patients, the drug of choice is amoxicillin. Orthopedic surgeons and physicians like amoxicillin, as well as dentists like amoxicillin, because it is it's known as a broad spectrum antibiotic, and that means it kills a lot of different microorganisms. So we want to choose the broadest spectrum antibiotic if we don't know what microorganisms we're targeting. So that's why we consider that our drug of choice. So for patients that are not allergic to penicillin, because we wouldn't prescribe amoxicillin to someone that's allergic to penicillin because of cross allergenities between the two cillins. So if someone's not allergic to penicillin, their suggested drug would be amoxicillin, cefalexin, or cephridine. And the dosage on that is 2 grams orally 1 hour prior to dental treatment. Usually with amoxicillin, patients will be taking 4 tabs of 500 milligram pills. So when I have a patient that says they pre-medicated, typically my question for them is, how many pills did you take? So I know that they took those 4 tablets, and a lot of times they've said, oh, I took 2. That's all I thought I needed to take. So we have to make sure that they're taking the recommended dosage, and it's important for us to know that recommended dosage. So if patients are not allergic to penicillin, but they're not able to take oral medications, we'll recommend ampicillin. If patients are allergic to penicillin, and this is pretty common, they will be taking clindamycin, and that is orally 600 milligrams. It's usually 2 tabs of 300 milligrams 1 hour prior to their dental appointment. And finally, patients that are allergic to penicillin, unable to take oral medications, there is a intravenous medication of clindamycin, and again, it's at 600 milligrams 1 hour prior to treatment. If it is a child that you're treating, it will depend on the child's weight to calculate their dose. If patients are coming in for multiple dental appointments within a short period of time, we typically have them pre-medicate with different antibiotics each time they come in. And the reason that we do this is to try to decrease the chance of creating antibiotic resistance. So if we have patients that are taking the same antibiotic multiple times in a short period, they can acquire antibiotic resistance. Their body can, the antibiotics won't work in their system because their bodies become resistant to it, and the bacteria in their body have become resistant to it. So we are prescribing these patients different medications, and it's a special different regimen that we follow. So the regimens listed here, I'm not going to quiz you on the regimen itself as far as the different medications, but I do want you to know that there is a different special regimen in that short period of time. This is a 9-day period, and multiple different kinds of antibiotics are going to be prescribed in that short period of time. And I want you to know that the reason for that is because we're going to try to reduce the risk of creating antibiotic resistance. This is our wrap-up slide for antibiotic prophylaxis and these key points that I want to make sure that you're touching on when you're studying. So there are 2 groups of patients that may require antibiotic prophylaxis and may have a recommendation for it. And those are the patients with heart conditions that have the highest risk, and those are going to require, those certain heart conditions are going to require an antibiotic prior to their dental appointment. And those with total joint replacements that may require, depending on the orthopedic surgeon's recommendations. So we're always following the physician or orthopedic surgeon's recommendations for their prophylaxis, even if they aren't following standard guidelines. So we know that the guidelines for joint replacement is to not premedicate, but a lot of times the physician will tell us to premedicate, and we follow what they say. They're writing the prescription for the antibiotic, and the patient is taking it. I want you to know what procedures would require antibiotics and which do not. So those are those that are high risk versus those that are low risk. And know that the prescribed antibiotics are dependent on the patient type. So depending if they're allergic to penicillin, depending if they can take oral medications or not, I do want you to know the recommended drug and the dosing for it. I definitely want you to know the dosing because that's important for us to know moving forward as dental hygienists and practicing on our own. And if a patient needs to take a prophylactic antibiotic for whatever reason their physician requires them to take a prophylactic antibiotic, a medical alert sticker is going to be placed on the upper right corner of the outside of the chart. If it's on the outside of the chart, there is nothing written on it. And on the upper right corner of the health history form, and that's going to have the reason for the medical alert written on that red sticker. Okay, on an unrelated topic, we're going to change gears and talk about substance abuse for the last couple slides. Where you would find substance abuse red flags on the medical history form, this is the back page, the top section of it, and highlighted there in purple are the questions: do you use controlled substances, in parentheses drugs, and do you use tobacco, and several different kinds of tobacco, and then it asks about if they're interested in stopping. So that would be a concern if a patient checked yes for those questions. It's frequent that they wouldn't check yes if it's something that they don't want to report to you, especially if they're using illicit drugs and not controlled substances. So there's other ways and other red flags that we can see to identify if a patient has a substance abuse problem. What is included in the term substance abuse? It includes controlled substances, illicit drugs, alcohol, and tobacco. Controlled substances are narcotics or prescription drugs that affect the central nervous system and can lead to addiction. They are controlled by the DEA, or the Drug Enforcement Administration, and these controlled substances are the most potent pain-relieving drugs. So you can imagine that we are prescribing these in dentistry when patients have severe tooth infections. Maybe they've gone through a large surgery in which they're going to be in a lot of pain afterwards. So these are controlled substances, are drugs that dentists will be prescribing, and they are controlled by the Drug Enforcement Administration. They're not allowed to be, there's certain categories, but the highest categories and levels that are most addictive are not allowed to be called in for patients due to the potential for fake identity theft and getting a hold of their doctor's DEA information and prescribing drugs to themselves or others by calling it in. So these drugs have to be handwritten and taken, prescription taken to a pharmacy. Illicit drugs, these are not prescription drugs. These are drugs that are more of your street drugs, marijuana, cocaine, methamphetamine. And these are going to be of high concern for dental professionals, especially as far as emergency situations are considered. And then alcohol and tobacco are also included, less likely to have true emergency situations, but very, very likely to have detrimental effects on the oral cavity. So for this class, we're pretty much going to focus on the potential for causing medical emergencies as far as substance abuse, and a lot of other classes will go into the more oral effects of all the different kinds of drugs, as well as alcohol and tobacco, and what they can do to the oral cavity as far as the teeth and the gums, etc. If a patient does not disclose that they may have a substance abuse problem, there are some red flags that we can try to recognize as clinicians that may indicate a drug issue. So, like I said earlier, drugs can have a really damaging effect on the oral cavity. So someone with chronic xerostomia or dry mouth, someone with rampant caries, so they come in and their whole mouth is, every tooth has a cavity or a carious lesion on it. Or someone who has rapidly progressing periodontal disease, far more than their age should indicate. So those can be some red flags to potential substance abuse. Also, there's a lot of medical issues that can be related to substance abuse. So especially younger people that have cardiovascular disease, history of a heart attack, myocardial infarction, if they have bloodborne pathogens from potential IV drug use, and potential for getting HIV or hepatitis from sharing needles with others. People who have liver dysfunction, alcoholics that have liver dysfunction, alcohol can greatly affect the liver's ability to function properly. And patients in general who are immunosuppressed, if we don't have another reason for why they have immunosuppression, potentially could be a red flag for substance abuse. And of course, if they have history of being in a recovery program, that is another red flag for us. We don't want to be giving them anything that could potentially cause them to relapse. And this could be something as far as prescribing them, if maybe they're in a rehab for controlled substances. So if we know that, we wouldn't really want to be prescribing them controlled substance or narcotics that they may become addicted to again in relapse. Patients who are in alcohol recovery programs, we wouldn't want them to be given a mouth rinse with alcohol in it, because that can start the effects up. They can swallow some of the mouth rinse, and that can just trigger them to relapse. So those are important things to be aware of when you're doing a head and neck exam and doing an intraoral exam, to be able to see those red flags for substance abuse. The first substance abuse we'll talk about is drugs. Controlled substances, there is a high rate of abuse with narcotics. We know that they are highly addictive, and once people start, it's very hard for them to stop. They are commonly prescribed in dentistry. I think with the high rate of abuse, a lot of dentists and a lot of surgeons are trying least to prescribe these to patients unless they really know that they're going to be in a lot of pain. And it's also important to note that patients that have controlled substance abuse issues and are taking a lot of controlled substances may have developed a tolerance and may need a lot more of the pain medication to not feel the pain anymore. And this can also have an impact in the dental chair because they can have a difficulty getting numb. So you need to give them a lot more anesthetic for them to actually feel the numbness. With illicit drugs, there is a significant reaction between cocaine and epinephrine, and this is one of our potential emergency concerns. So we know that cocaine raises a patient's blood pressure, it raises the pulse, it also raises or greatens the force of the heart contraction, and it also promotes vasoconstriction. So we know that cocaine is an upper, so that's how you can kind of consider an upper. It raises the blood pressure, it raises the pulse rate, it makes everything faster. So it's a major cause of heart attacks among young adults and has a significant reaction with epinephrine. So if we are planning to use epinephrine during a dental appointment and we know we have a patient that it has a cocaine addiction or abuses cocaine, we should have the patient not use for at least 18 hours prior, or better safe than sorry, choose an anesthetic that does not have epinephrine in it so that there is no potential for us to even raise that patient's blood pressure higher if they've used recently. Hopefully we know, but there's a potential that the patient could seem okay and still have effects of the cocaine, and then we'll be in a big problem. So it's usually best to just choose an anesthetic without epinephrine. To manage patients that have history of drug abuse, we want to make sure we're carefully reviewing that medical history, determining if there's any bloodborne diseases such as HIV, hepatitis, and that could be from IV drug use and sharing needles. If there's any liver disease or immunosuppression, we also need to see if they potentially need antibiotic prophylaxis. So if they're an IV drug user, they're more at risk for infective endocarditis because of sharing needles, and that there's that Staphylococcus aureus we talked about in the previous lecture that's present on the skin. So sharing IV needles can potentially put users at risk for infective endocarditis, and that would be something that would be recommended by a physician. It's recommended to use non-opioid or non-narcotic analgesics for pain control. We don't want to be prescribing patients medications that they're going to have an abuse issue with. There's a lot of other ways we can control pain without using narcotics. So in my office, the most commonly prescribed antibiotics are ibuprofen, a prescription strength ibuprofen, and we tell patients to supplement that with over-the-counter Tylenol. Those are two non-narcotics, and it's very effective in preventing a lot of pain. So we very rarely prescribe controlled substances, especially narcotics. And also you want to make sure you're aware that local anesthesia with a lot of illicit drugs do not mix well because of the epinephrine. So it's best to just avoid a local anesthesia with epinephrine. There are a lot of concerns when it comes to alcohol and tobacco abuse for dental professionals. In this class, we're only going to focus on the emergency concerns. We have plenty of time in other classes to go over the others. So for alcohol and tobacco abusers, there is a decreased immune system, decreased immune response to fighting off infections. So patients that are alcohol and tobacco abusers could potentially have decreased healing and an increased risk of infection, and that could potentially lead to an emergency concern if they get an infection. Alcohol abuse patients have decreased liver function, especially if they're a chronic alcohol abuser for a long period of time. And they may have excessive bleeding, so that would be something that we would have to be careful to monitor. We also have to be careful of the medications that we prescribe, because a lot of medications are metabolized in the liver, and if a patient has decreased liver function, that wouldn't be good for the patient to handle. And always, if the patient is under the influence of any controlled substance, illicit drug, tobacco, or alcohol, you would definitely not want to treat that patient. You will be rescheduling the patient if they are under the influence. Again, the book goes into a lot more detail about substance abuse. For this class, we're only going to be focusing on the emergency concerns.